Hello everyone, this is Professor Harkirat Bal, and today I'm back with another very important topic, caring for clients with somatic symptoms disorders and dissociative disorders. Now, these are two distinct but sometimes overlapping areas in mental health, and that's why I decided to combine these topics. This will be a relatively short lecture. It's not going to be a long lecture at all, but please don't let the length of the lecture fool you, because caring for these patients is anything but simple. In fact, in my opinion, these clients are some of the most complex and time-consuming to care for. So their presentations often involve multiple symptoms and require a great deal of empathy, reassurance, patience, and clinical judgment. So let's explore how we can better support and treat these individuals. We'll begin with somatic symptom disorders first. The term soma comes from the Greek word meaning body. Then we came up with a term called somaticization, which is the expression of psychological stress through physical symptoms. And there's no evidence of those symptoms. So we have done extensive medical workup, investigation, and we really can't figure out why the patient is having physical pain or physical symptoms. Example would be, so remember there are two things going on. You have a client with expression of a psychological stress through the physical, right? So psychological stress, let's say you have a client with anxiety or depression and so forth. So this is your psychological stress, and patient is giving you a symptom, a physical symptom. Presentation is that I have abdominal pain or back pain, whatever the case is. Patient may report either some kind of a neurological symptoms such as paralysis, or maybe dermatological symptoms such as skin rash and so forth. So pretty much the patient is giving you symptoms, unexplained symptoms, and you have done extensive workup and you really can't figure out the cause behind it. All right, so some other example would be GI symptoms perhaps, and GU symptoms, musculoskeletal, sensory, maybe cardiac, chest pain, and so forth. DSM-5 talks about somatic symptom disorder. That's a term, the umbrella term, I should say. Previously, we used to call as a somatoform disorder or somaticization disorder, but now, according to DSM-5, the umbrella term is main category is a somatic symptom disorder. There are 7 somatic symptoms disorder listed within that category in DSM-5. The first one is somatic symptom disorder. I know it's kind of confusing, but the first category, subcategory within that class is a somatic symptom. Second is illness anxiety disorder. Number 3 is conversion disorder. Number 4 is the psychological factors affecting other medical conditions. Number 5 is factitious disorder imposed on either self or on others. That's one category. Number 6 is other specified somatic symptoms and related disorders. And then the last one, number 7, is unspecified somatic symptoms and unrelated disorder. So let's talk about them very briefly, one at a time. We'll start with the number 1, somatic symptom disorder. So you have a client giving you a bunch of symptoms such as pain, fatigue, and so forth, and you just need to meet one criteria, and the patient also, along with the physical symptoms, patient is presenting with, a patient is worried or has some stress associated with those presentation with those symptoms. All right, let's see. And duration is that it has been bothering the patient for at least 6 months or so. All right. And symptoms can migrate. What do I mean by that? So it's possible that the primary symptoms maybe in the beginning was pain, and then patient switched that symptom from pain to maybe nausea or something else, maybe blurry vision, whatever the case is. So it is possible that the symptoms may switch. So the patient focus will switch from one symptom to another, and then they may go back and forth. Um, the point here is that they have excessive thoughts, or the feeling about those somatic symptoms, and it's been going on for the past 6 months or so. And if the primary symptom is a pain, then we can specify that somatic symptom disorder with predominant pain, if that is the issue. And also we can specify if it's persistent and what is the severity. According to DSM-5, we can categorize that either mild, moderate, or severe. Second example under somatic symptom disorder is illness anxiety disorder, IAD. We used to call this as hypochondria. So we no longer use the term. The official term is illness anxiety disorder. So you have a client with, I still remember that as a hypochondria. It's much easier uh, to come up with examples because we are familiar with that term, right? Anyways, you have a client who's preoccupied with a fear of having a serious disease based on some misinterpretation of symptoms, right? But there is an impact on their ADLs. So these clients, they worry about a cause and consequences of a bodily symptoms, and the duration is of 6 months. These are the patients, you have done extensive workup and then you cannot reassure them. So they do, a provider shopping, if you will, because they're not satisfied with your answer. So you have done, gosh, endoscopies and colonoscopies and CT scan and so forth, extensive workup, and they're not satisfied with the answer. Very difficult to reassure. Somatic symptoms are either absent or very mild. So what do I mean by that? So the patient is telling you that I have these symptoms, but the symptoms are not present, or if they are present, they're very, very mild. One intervention could be CBTC. The point here is not to treat that symptom with the medication, because then that's not a good thing. For example, the patient tells you have a pain, we really should not be giving them narcotics, or if the patient tells you have anxiety, then we should not be treating these patients with benzodiazepine, very, very addictive, right? So the best treatment of choice really should be CBT. We'll talk more about the treatment as a group in a minute. And screen for comorbidities and plus minus SSRI. Okay, number 3 is a functional neurological symptoms, and we used to call that convergent disorders. Okay, so one or more symptoms or a deficit affecting voluntary, motor, or sensory function that suggest a neurological or other general medical conditions. These symptoms are not intentionally produced. Very, very important concept. So the example would be pseudo seizures, blindness, paralysis that cannot be explained neurologically. So again, they are not doing it intentionally, but they do have these symptoms and we have no evidence. We are doing the extensive workup. We cannot explain. Then they fall under somatic disorder, more specifically functional neurological symptoms. Again, offer reassurance. This should say reassurance, not recurrence. And CBT. All right, number 4 is the psychological factors affecting other medical conditions. That's the fourth category. You have a client with a medical symptom or a condition other than a mental disorder. So behavioral factors that adversely affect a medical condition by increasing the risk of suffering, disability, or death. What do I mean by that? Let's say you have a client with anxiety, so that is your mental disorder, with another medical symptom or condition. So in this case, it's asthma. So a patient with anxiety is going to have asthma exacerbation, or a client with a diabetes, that's your physical problem, who is going to manipulate their insulin dosage in order to lose weight, and they're doing that without the consultation of their prescriber. So these are psychological factors that are affecting other medical conditions. And number 5 is factitious disorder. Well, factitious disorder involve physical or psychological symptoms that are intentionally produced. So there's a falsification in order to gain attention from a potential caregiver with no secondary gain. This is very, very important. Yes, they are intentionally producing those symptoms, but there's no evidence of secondary gain or external reward. In other words, they're not doing it because of any financial gain or trying to claim any disability or anything like that. Um, Remember, this is different. This is different from convergent disorder. Convergent disorders, they were not reporting. They were not making those symptoms intentionally. So this is different from number 3 that we just talked about. These clients are motivated by an unconscious desire to inhabit a sick role. I hate to say that, but just lack of better terminology, they enjoy being sick, to take that sick role, if you will. The intention to fabricate symptoms distinguish factitious disorder from somatoform disorder. We just talked about that. Now, you can further divide factitious disorder into 2 categories. Factitious symptoms imposed on self, which is more common, about 90% of the patient. Not 90% of the overall population. I'm saying the 90% of the client diagnosed with the factitious disorder will fall under this category. Patient often, so they're imposing on self. In other words, they're harming themselves. They're injecting themselves with a higher level of insulin to produce hypoglycemia, or inject feces to cause infection, or ingest blood to induce, emesis and so forth. Now, the second subcategory would be factitious syndrome imposed on other, and that's a remaining 10%. And other name for this is Munchausen syndrome by proxy, and this is when parent is making, well, it could be imposed on anybody, but most of the time it's parent, and usually these are biological mothers making their own child sick, giving them injection, causing hypoglycemia, whatever the case is. There have been many documentaries on this topic. All right. Number 6 is other specified somatic symptoms and related disorders. What do I mean by that? Well, it's other. Well, just like in anything else in DSM-5, when you have a client who's giving you symptoms that are causing distress and so forth, but do not meet the full criteria for any of the disorder that we have talked so far, will fall under this category. Other specified. And number 7 is unspecified somatic symptoms. What do I mean by that? Again, it's unspecified. We don't know, but do not meet the full criteria for any of the disorder. So it's anytime you cannot specify, then fall under unspecified. We should try our best to specify things as much as possible. So the unspecified somatic symptoms should not be used, as I mentioned, unless there are, you know, there's no enough data. You have insufficient information to make a more specific diagnosis. One example I'll give you, maybe this will help you to understand this concept. Let's say you have a client with infection. You can say an unspecified infection, you have no clue, but we should try our best to find out, is it a UTI, is there ear infection? If it's ear infection, well, that's more specific than just infection. And then we should really further specify if it's a left ear or right ear, right? We should know that. Amputation, which one is a right or leg? We should know. DVT of upper or lower extremity, and is a right or left extremity. So try your best to be more specific. We need that when we use ICD-10 codes. All right. So how do you assess these patients? Again, what are their psychosocial factors? What's underlying cause? Is there any comorbidity? What type of coping skills do they have? Um, Spirituality and religion. There's enough data. Then people who are not necessarily they believe in God, but if they are spiritual, they tend to recover faster, or overall mental health um, recovery is better, I should say. Do they have any secondary gain? What type of cognitive style they have? Can you identify any ineffective coping? And how can we replace that with healthy, effective coping skills? So what do you do? Well, interventions would be, again, first of all, a therapeutic communication skill. Be active listener. Make sure you understand that that their concerns are genuine, right? So they need to know that you are showing that skill of empathy, if you will, that I understand. You do not minimize their concerns. Make an eye contact. Be a good listener, if you will. Don't judge them. Ask open-ended questions, and so forth, right? um, Anyways, schedule regular follow-up visits for them. That way they don't feel neglected. They don't shop around. You want to be on top of all of their concerns, and offer coping skills, and maybe they can get a benefit from CBT. Maybe arrange that. SSRI may be beneficial in some patients. However, try your best not to prescribe psychotropic, benzodiazepine, and so forth, or maybe narcotics. Be very, very careful. Um, uh, if you have to, of course. I mean, I get that. I'm not saying never prescribe. I said be very, very careful. And then just offer them reassurance. Um, All right. So that was a somatic disorders. Second part is dissociative disorders. Now, the hallmark of dissociative disorder is the disturbance of or alternation in the normal integration of a consciousness, memory, identity, emotion, perception, body representation, motor control and behavior. These clients, they will give you symptoms that can be potentially disrupt every area of a psychological functioning. So there are, just like we had 7 categories under somatic disorders, we have subcategories under dissociative disorders as well. The first one is dissociative identity disorder. Then you have amnesia, depersonalization, and derealization. That's one category. That's number 3. And number 4 is other specified. And number 5 is unspecified. So we'll start with the number 1, which is dissociative identity disorder. All right. So next topic, the first topic is dissociative identity. So this is when you have a client with disruption of identity, um, characterized by 2 or more distinct personality states. Um, we used to call this as a multiple personality disorder. So when you have a client who is dealing with, lack of better terminology, multiple personality or more than one. Now, dissociative amnesia, the second subcategory, is you have a client with inability to recall important event. Usually, it's a result of some kind of a traumatic or stressful um, um, injury or insult to the brain. So maybe after rape, or somebody saw a murder, or maybe, I don't know, a car accident, and they cannot recall the steps, or they can describe the scene, or they have no memory. All right. All right. So next is depersonalization and derealization. Now, the difference between them is in the first one, you have experience of unreality, detachment, or being an outside observer with respect to one's thoughts, feelings, sensation, body, or action. Here you have experience of unreality or detachment with respect to surroundings. So the example here would be a distorted sense of time, unreal or absent self, physical numbing, and here on the second example is um, individuals or objects are experienced as unreal or dreamlike, foggy, lifeless, or visually distorted. Um, a patient with depersonalization may feel cut off from his or her thoughts, emotions, or identity. And then you have other specified disorder, just like we talked about, do not meet the criteria, or unspecified disorders when you don't have enough information. All right. Now, how can we help them? What are some interventions? While there's no standard treatment, CBT can be offered so that the client may learn to confront their disordered thoughts and challenge their feeling of unreality. And plus minus SSRI. SSRI seems to be effective, and we talked about that in somatic disorder as well. And maybe plus minus benzo, like for example, diazepam 5 milligram 3 times a day or so. As you can see, there's no a clear treatment or a standardized treatment approach. Anytime we are addressing a client with either somatic symptoms or dissociative symptoms, my best advice is to actually refer them for CBT. Okay, so the last topic here is malingering. Very important topic, very sensitive topic. So I do want to spend some time on this. So first of all, what is malingering? Well, this is when you have a client who is perhaps lying to you, right? They're either faking their symptoms altogether, or perhaps the symptoms are very mild and they're over reporting, they're over exaggerating those symptoms. And why would they do that? Most likely to get some benefit. What are those benefits? They can be either to gain something or to avoid something. Gain something means either gain some medications, maybe benzodiazepine or narcotics and so forth, or avoid something such as avoid some maybe legal responsibilities, child custody, or I don't know, so some other legal responsibilities, maybe like in during criminal investigations and so forth, right? Okay, or maybe to get some disability, to get some other benefits. Now, this is very different from factitious disorder that we talked about earlier, where symptoms are fabricated, but the motivation is internal. They just wanted to assume the sick role, remember, but there was no external reward for those patients, the one that we talked about under factitious disorder. Now here there's a clear external benefit, so that's a different. Now this is a more of a differential diagnosis. This is not a psychiatric condition or a medical diagnosis. This is a behavior, and this should be part of our differential diagnosis. Now, this really put us in a very difficult situation. It becomes an ethical dilemma. Should we trust our patients or not? I tend to trust my patient anytime a patient tells me about, let's say, PTSD or I don't know, pain, and I tend to believe them. And remember, my setting is inpatient, and then I believe that the overall burden of the disease is so overwhelming and they're admitted, so I tend to treat them a little bit more aggressively, if you will. But I can see as an outpatient standpoint of view, where I believe these symptoms are or these presentations are maybe more common than the inpatient. So I can see how it can become ethical dilemma. Do we report, or do we further investigate or not? So that really gives like two school of thoughts, if you will, where some people believe that we should investigate and confront these patients, and and some people believe that, well, what if I'm wrong? What if they're right? And if we start telling them, no, you're lying, and then we will lose that trust altogether. And there's a stigma attached to these conditions anyways, and then they will not open up, they will never come back to you, and we will miss that opportunity. So I see that, right? I can see that as an issue. So very quickly it becomes very ethical dilemma. So I mean, I don't know the answer to this issue. I think my best advice is probably know your patient very well and see if they are meeting the criteria, and listen to them, obtain a very good history, if you will, and just avoid rushing to label these patients. I guess always look for some medical or psychiatric reason to explain those symptoms before we tell them that I don't believe you. And in general, I personally believe malingering is relatively low in a day-to-day clinical settings, if you will, especially in inpatient. But it really depends on the setting again, right? Maybe in the ER, if you have a same patient coming back over and over again for a chronic back pain, let's say, or PTSD, but you really, and you have done all the workup and there's nothing there, perhaps the question should come up, are we really dealing with a behavior instead of a psychiatric disorder now? And there's no exact data, unfortunately, just because of the nature of this subject, if you will. And I have read so many articles, journals, where people believe that in forensic or legal settings, especially with the personal injuries and after car accident and so forth, people do over-report their back pain, let's say. So the malingering rates are much higher in some, even like a PTSD cases, than in inpatient, let's say a client who's suffering from let's say depression or schizophrenia, and if they are reporting insomnia, let's say, then I tend to believe them, right? The rate of malingering is less in that setting as opposed to the other example that I just gave you. I think the summary is the rate really depends on the setting. In one clinic, in one setting, it could be as low as 1%, 1 to 5%, and in some other settings, it could be as high as a 20 to 30% maybe, and especially with the criminal cases, let's say, or the forensic legal settings. And overall, we know that
It is a huge burden financially from the insurance company's standpoint of view and so forth. I know it cost us like billions of dollars annually. One important tip I'll give you is, if you truly believe this is a case of a malingering, before you really confront your patient, make sure you're 100% sure, and then second thing is make sure you alert somebody. I don't want you to be in a situation where you are telling your client that you do not believe them, and now they get really agitated, and then you are in danger. Okay, so please make sure you have a help available, and make sure you're right, because what if you were wrong and they were right? So that would be a very bad situation, of course, right? All right, I think we talked about this. Look for some clues that will help you if this is a case of a malingering. For example, there's no consistency, there's a discrepancy with the report, and they do not want you to do a proper assessment. They just want you to give you a medication, let's say. Or they're giving you too much information all at once. They have read the, let's say, the DSM criteria and then giving you all the information, because in real situation it takes a while for us as a clinician to get that information out of them, right? But if you're giving you everything up front as if they have memorized the criteria, that can be red flag as well. Not always, of course, right? It's maybe possible that they know their condition very well and they have been doing some online research. So again, you have to go back and forth. Do I trust this information, and maybe get some collateral information as well. So take a look at it, and then be very, very careful. I just do not want you to think of malingering as a number one differential. This should be part of your differentials, but not on the top though. Okay, you have to listen to your patients. And that's all I have for now. As usual, please feel free to contact me if you have any questions or concerns. And thank you so much for your time. I will see you next time with a different topic. Bye for now.